We are just opening our webinar space for today, and I want to extend a really warm welcome to all that are joining across time zones and across spaces. We're just going to give a couple of moments for people to sign in and get online. And as people are coming on, just an incredibly warm good morning, good afternoon, good evening to all that are joining across many time zones and many spaces. It's great to see everyone here together. As people are signing on, I'm going to go ahead and just continue our welcome. I'm Michelle Decker. I'm a professor here at the School of Public Health and have the pleasure of being our director for the Center for Global Women's Health and Gender Equity here at the school and at the university. And we are really thrilled to be able to present this webinar today as part of our Evidence Accelerators webinar series. For those that are signing on, our Evidence Accelerators cohort through really made possible with the generous support of the Packard Foundation has allowed us to work with an incredible cohort of practitioners and scholars from around the world over this past year, specifically on topics of gender equity and gender-based violence in particular, through a combination of virtual coursework, mentoring, and in-person cohort gatherings. We have been incredibly honored to be part of the learning and the growth trajectory for our evidence accelerators, and we'll be hearing from 4 of them today. The purpose of the program is to build skills and networking and experience in bringing evidence-based advances to the space of gender equity, including GBV. And today we are hearing from really a set of diverse colleagues and accelerators across a number of regions and some really important topics. And I'm just incredibly delighted to welcome everyone. I'm going to turn us over to my colleague, Dr. Shannon Wood, for the introductions and to kick off our session for today. And again, an incredibly warm thanks to all those that have gathered today. Dr. Wood, over to you.
Hello, everyone. Good morning, good afternoon. It's so wonderful to see all of you. Thank you so much for joining us. I've had the immense pleasure of working with these scholars and the rest of our 12 scholars throughout the course of the year, and really just seeing their work expand, their analysis skills grow, and I think we have a real treat today just in terms of the final products for these projects. So I am thrilled to first introduce Nada Ben Jemaa, who is currently a postgraduate student of politics at the University of Cape Town under the Mandela Rhodes Scholarship. When she began with us, she was at UNFPA's Tunisia office as a GBV program officer, and the title today of her presentation is Technology Facilitated Gender-Based Violence and Mental Health Outcomes in Tunisia.
Hi everyone, thank you for tuning into the webinar. I'll be presenting my work on technology facilitated gender-based violence and its mental health outcomes in Tunisia. This research work looks into the prevalence of tech-facilitated GBV among Tunisian women users of internet and who is at risk of this type of violence. It also looks into the impact of tech-facilitated GBV on the mental health of women using internet in Tunisia. This topic matters because TFGBV is growing exponentially around the world with varying prevalence rates across countries and regions. UNFPA conducted a study recently that covered 18 countries and showed that nearly 60% of women with internet access have experienced at least one form of tech-facilitated GBV. This prevalence rate is almost double that of the global average prevalence rate of intimate partner violence. In Tunisia, 70% of the population uses the internet, that is equivalent to over 9 million internet users, and this widespread digital connectivity offers numerous benefits, but it also led to a surge in tech-facilitated GBV, particularly affecting women and young people. The psychological impact of tech-facilitated GBV on victims and survivors remains very much under-researched. While prevalence and forms of tech-facilitated GBV have been documented in the past, there's a notable gap in understanding its mental health consequences on the victims and survivors. The conceptual framework we chose to follow looks at the types of TF-GBV, the frequency and severity of the violence, and the relationship to the perpetrator. It also factors in individual, societal, and technological factors, leading to the impact on mental health, with elements such as resilience, coping mechanism, and professional help-seeking behavior affecting their results. The possible outcomes are classified into 3 categories: direct impact, indirect impact, and stigma. The methodology we followed consists in a secondary analysis of a dataset collected by UNFPA Tunisia through a phone survey that was administered to 1,003 participants. This secondary analysis, however, was limited to a subsample of 741 women aged 18 plus who reported using communication technology. The demographic data collected included location, level of education, and age. The experience of tech-facilitated GBV was measured using a 17-question survey of lifetime experience of any of the 14 types of tech-facilitated GBV that were identified by UNFPA in its global report on tech-facilitated GBV. The survey included other questions on awareness of the phenomena and social media platforms on which the respondents experienced it. As for the impact of tech-facilitated GBV on mental well-being, it was quantified using the Warwick-Edinburgh Mental Well-being Scale. So the parent study is titled Technology-Facilitated Gender-Based Violence in Tunisia, Prevalence, Types, and Impact on the Quality of Life and Mental Health of Victims. The exposure in the first research question we addressed is education, age, and region, with the outcome being TF-GBV exposure. And for the second research question, the exposure is TF-GBV and the outcome is the Warwick-Edinburgh Mental Wellbeing Scale score. The analysis conducted showed a tech-facilitated GBV prevalence rate of almost 60%, with online sexual harassment, cyber-obsessive pursuit and surveillance, and online harassment being the most prevalent types. As for demographic factors, the study showed that women in Tunis metropolitan area, women with higher education levels, and women aged 18-24 are more exposed to tech-facilitated GBV. We also ran a logistic regression for sample characteristics and exposure to TF-GBV. The trend in values shows that the likelihood of exposure to tech-facilitated GBV increases with increase in education levels and decreases with increasing age. As for the Warwick-Edinburgh Mental Wellbeing Scale, the overall score is a sum of the individual scores for the above questions. It ranges between 14 and 70, and its mean is 47.8. Now, the mean score for those with TF-GBV exposure is 47.01, and the mean score for women who have not been exposed to TF-GBV is 48.85. The means here are significantly different. You can see in the graph the difference in score per individual question by past experience of TF-GBV. The key findings here are the association of location, level of education, and age group with experience of TF-GBV in Tunisia. There is also a proven link between tech-facilitated GBV and reduced mental well-being among survivors and victims in Tunisia. As for the action steps, on the policy level, we recommend advocating for the recognition of TF-GBV as an emerging public health issue in Tunisia, including stricter enforcement of Law 58 and adoption of implementing texts for this same law that would explicitly include provisions addressing TF-GBV. We also recommend organizing specialized training for lawmakers, government officials, and ministry staff to deepen their understanding of the complex nature of TF-GBV, including its different types, its root causes, its emerging trends, and also its health impact. We also recommend adopting policies requiring social media platforms to implement stricter content moderation, more effective reporting tools, and user protection mechanisms. This is all to better accommodate local users, particularly regarding the local language and dialect. We also recommend integrating cybersecurity education into school curricula, starting from primary school. That would allow us to equip children with foundational knowledge on safe online practices and digital literacy. As for intervention level, It is recommended to launch nationwide campaigns to educate the public about TF-GBV and its impact on mental health, the content of which would be tailored to the targeted audience. The idea here is to be able to leverage Tunisia's high internet penetration rate to spread awareness about TF-GBV, using mainly platforms that are most commonly used in Tunisia, like Facebook, Instagram, and TikTok. We also recommend training service providers at dedicated support centers for GBV survivors on TF-GBV, on the specific needs of the survivors of such forms of violence and the care required. We also recommend training healthcare professionals, psychologists, social workers, and law enforcement personnel to recognize and address the unique challenges that this form of violence presents. It's also recommended to expand the services of the Ministry of Women's Affairs hotline to include dedicated support to TF-GBV survivors that would ensure the anonymity and ease of access. As for research and knowledge production, we encourage the Tunisian universities, particularly those specializing in psychiatry, psychology, and sociology, to conduct research projects on this form of violence, to offer research grants and facilitate collaborations with NGOs and international organizations. It's also recommended to conduct a nationwide survey to monitor the prevalence of the known forms of TF-GBV and assess any potentially emergent form. And that would be conducted on a regular basis. The goal of this is to have a centralized, anonymized database to monitor and analyze TF-GBV trends in the country, and that would enable, on the long run, better policy making. It's also, it would be also very interesting to investigate how sociocultural factors in Tunisia, such as family dynamics, societal expectations, how these factors influence the experience and the reporting, as well as the healing of TF-GBV in the country. Thank you all for your attention.
Thank you so much, Nada. That was such an amazing overview of some of the issues that are occurring in Tunisia. And I know that tech-facilitated GBV is a major focal point right now for UNFPA and also for many working in the GBV space globally. Just a quick note to everyone. So our presentations today are pre-recorded just to make sure that we don't have any tech hiccups. All of our speakers are here today, though, and very ready to answer any questions that you might have. If you have any questions, please go ahead and put them in the Q&A feature at the bottom of Zoom, and we will cover them all at once after all four speakers have gone. And I think that this will just allow for a really rich discussion and comparison across our context as well. Okay, I'm thrilled to introduce our next speaker, Abigael Malelu-Gitau, who's a gender and education consultant, researcher, and doctoral student in gender studies. She's the founder of Scars of Resilience, a community-based organization in Kenya. The title of her presentation today is Help Seeking and Professional Working Status Among Survivors of Intimate Partner Violence in Kenya, a Comparative Study.
Welcome to my presentation on help seeking and professional working status among survivors of intimate partner violence in Kenya. And this is a comparative study. So the research questions are two, and the first one is, among survivors of physical intimate partner violence, how does formal help seeking differ between professional women and non-professional women? The second question is, are there formal help-seeking differences by severity of physical intimate partner violence, that is, between severe versus less severe by professional status? The justification of this study lies in that existing study, as noted by Kwesinga, primarily target women in low-wage and low-status position, overlooking the growing number of professional women in the labor force. Existing research has shown that women in paid labor experience heightened levels of intimate partner violence. Often, this is due to male backlash against the shifts in traditional gender roles. And despite having access to greater resources and organizational support, professional women may still face significant barriers to effective help seeking for physical intimate partner violence, largely due to entrenched gender norms. As such, understanding differences in help seeking by professional status will inform targeted interventions, particularly for professional women whose help seeking behaviors may be influenced by their unique social professional circumstances. Looking at our conceptual framework, we have our independent variable, which is professional status, and we have our dependent variable, which is the help-seeking behavior. And this help-seeking behavior, we have severity of abuse that may act as a moderating factor, and individual factors such as age, education, and social economic status, as well as relationship factors, which may act as confounding factors. So, the source of our study is from the Kenya Demographic Health Survey that was conducted in 2022. And our sample consists of partnered women who are aged between 25 and 49 who have worked. So the working age mostly in Kenya starts from 25. And therefore, these are people who have worked within the past year and experienced physical intimate partner violence within the past year. The main exposure is professional status of past year work, and the outcome is the formal help-seeking behavior. The severity of physical intimate partner violence, which we have seen, is either severe violence or less severe only. So severe violence may consist of both severe and less severe, whereas less severe, it's only less severe violence only, as defined by the Demographic Health Survey. So the sample population consists of 1,044 women, and in it we have 825 who are non-professional and 219 professional women based on the Kenya Demographic Health Survey occupation classification. So into our findings, the first one is the professional status. We found that 16.6% were professional women and 83.4% were non-professional women. Looking at help seeking, at first we sought to understand seeking any help. And we saw that from our sample, 50.4% had sought any form of help. However, when looking at seeking formal help, we noted that only 10.4% had sought formal help. Now, seeking formal help in this case refers to seeking help from social services organizations, religious leaders, lawyers, or even doctors. Now, looking at formal help seeking behavior by professional status, overall, and also by violence severity, we note certain things. We start with the first one, that is overall help seeking behavior by professional status, and we note that 12.1% of professional women sought help as compared to 10.1% of non-professional women. So the p-value is 0.514, which shows that there was no significant difference between the two. On looking at the severity of intimate partner violence, when faced by severe physical violence that may have both severe and less severe, we noted that 19.3% of professional women sought help as compared to 12.0%. So looking at that p-value of 0.146, it may not be significantly it may not show some significant relationship. However, it is trending towards significance, as we are going to see. Lastly, when looking at less severe, 3.3% of professional women sought help as compared to 6.7% of non-professional women. So again, the p-value of 0.365 shows that there was no significant difference between the two groups. What are the implications of our findings? So we note that these findings suggest that whether a working woman is a professional or a non-professional, it does not significantly influence her likelihood of seeking formal help for intimate partner violence. We also note that while not statistically significant, I had mentioned, with a p-value of 0.146, among women who experience any severe intimate partner violence, professional women were marginally more likely to seek help than non-professional women. So we saw that 19% of professional women sought help as compared to 12% of non-professional women. So these findings suggest that internalized barriers to help seeking may affect both professional and non-professional women similarly. As such, interventions should address gendered social cultural barriers that prevent working women from seeking help. While overall prevalence of help seeking is similar by professional status, future research should attempt to explore differences in the mechanisms and types of help seeking between professional and non-professional women. So the strategies that we recommend are: 1, adopting the power of storytelling from survivors of intimate partner violence to reinforce positive attitudes towards help seeking. So we know the power of storytelling can really bring people out to talk or seek help. Again, establishing one-stop centers and making them accessible for comprehensive survival support. 3, designing specialized programs within organizations and professional networks to address intimate partner violence in workplaces, and encourage workplaces to develop policies that support help-seeking behavior among survivors of intimate partner violence. These may include safe spaces in offices, paid leave, and protection policies after disclosure. We also recommend leveraging on technology, such as mobile applications. For example, we have My Plan Kenya, and this one is going to provide survivors with resources and guidance on formal help-seeking services while ensuring confidentiality. Welcome, and thank you so much for listening.
Thank you so much, Abigail. Really important implications for help seeking for women in Kenya. And really appreciated you walking us through those results so clearly. And even if you didn't find significant differences between professional and non-professional women, just diving into those implications and different ways that we can support women experiencing violence. Okay, our next speaker today, we are now hopping to Armenia. Our next speaker is Lusine Aslanyan, who is a lead researcher and consultant at the Coalition to Stop Violence Against Women, an organization that's based in Armenia. The title of her presentation is Individual Level Awareness about Existing Support Services for Victims of Gender-Based Violence Among the General Population of Women in Armenia. Thank you, Lucy.
Good morning, good afternoon, and good evening, everyone. Today I will be presenting our research on individual level awareness about existing support services for victims of gender-based violence among the general population of women in Armenia. This research was conducted through the GHGE Gender Equity, Gender-Based Violence Evidence Accelerator Fellowship and the Coalition to Stop Violence Against Women, which is a leading organization combating gender-based violence and supporting survivors in Armenia. Our research aimed to answer 2 key questions. First of all, we wanted to understand what is the individual level awareness of the availability of existing violence against women and girls support services among the sample population in Armenia. We also wanted to see how does awareness of services differ by socio-demographic and other relevant factors. So why is this topic important? Even though gender-based violence and gender equity is improving in Armenia, but there are still major challenges that are remaining to be addressed. According to Armenian Demographic Health Survey conducted in 2020, about 1 in 4 women aged 15 to 49 experience some sort of physical, sexual, or emotional violence from their intimate partner at least once in their lifetime. Even though support services exist, many women remain unaware of these services, and addressing the disparities is crucial to ensure that women get the support and the services that they need. Through our conceptual framework, we looked at how sociodemographic characteristics such as age, district, citizenship, education, employment, income, marital status, disability status influence individual level awareness about the support services. The data that we used was from a survey on the reach of violence against women and girls support services conducted through the coalition in 2024. The sample included 393 adult women aged 18 to 63 recruited from primary healthcare facilities from 3 cities in Armenia. The exposures that we looked at were sociodemographic characteristics, as well as individual perceptions about women's rights. These perceptions were categorized by fully or mostly protected, partially protected, a little or not protected. And the outcome that we looked at was individual level awareness of violence against women and girls support services, again categorized by aware, not aware, uninterested, not aware, no access to information. The mean age of our study participants was about 42 years. The majority of them had less than a university degree, were employed with an income of about less than $350 US, did not have a disability status, were either married or living with their partner, were Armenian nationals living in the capital city of Yerevan, and the majority of them believed that women's rights are only partially protected in Armenia. Most of the women were either aware or not aware and did not have access to information about the support services. As the education level decreased, so did the awareness levels of the support services. Disability status was also a significant factor shaping the level of awareness for this particular group. Women living with a disability were less likely to be aware of such services and were more likely to be uninterested. Finally, city of residence was also a significant factor influencing level of awareness. Especially women living in Gyumri were less likely to be aware and have access to information about the support services. So based on our findings, we came up with several actionable recommendations. We think that it is important that programs consider simplifying their messaging to ensure that it is easily understood by women with different literacy levels. It would also be beneficial to ensure that the information is available in accessible formats such as Braille, sign language, easy read versions, and that the physical spaces that are offering these services are both available and accessible. Targeted city-based interventions could also address disparities. We think that organizations should collaborate with community-based groups, disability advocacy organizations, and women's rights groups to expand outreach and inclusivity of awareness campaigns. It would be helpful to hold workshops in primary healthcare facilities through the primary healthcare providers, as well as community centers through community workers to educate women about their rights and the support services available to them. And finally, it is important to establish systems that regularly collect data from women, both on the accessibility and effectiveness of services to ensure that continuous improvement and responsiveness takes place. Thank you so much, and I will look forward to your questions.
Thank you so much, Lucy. Really important points there, just building on this conversation about help seeking. And it's not just enough to establish those support services, but make sure that women are really aware that they exist and that a diverse group of women are aware that they exist. And appreciate you describing some of those accessibility features that could be put into place. Okay, our last speaker is getting back to our topic a little bit more about emergent and understudied forms of GBV. So I'm thrilled to introduce Lorato Modongo, a gender research and policy analyst at the African Union International Center for Girls and Women's Education in Africa, based in Burkina Faso. This is a technical office of the African Union mandated to advance girls' education in the continent. The title of Lorato's presentation is Improving Understanding of Emergent and Understudied Forms of GBV in Botswana in alignment with the SADC GBV strategy, a policy analysis.
This policy analysis sought to answer two research questions. One, what are the gaps within the old Botswana National GBV Strategy 2015 to 2020 regarding emergent and understudied forms of GBV? And secondly, drawing from the Southern African Development Community, SADC, regional strategy on GBV, what are the key recommendations for the next GBV strategy in Botswana? Specific to emergent and understudied forms of GBV, such as tech-facilitated abuse and intimate femicide. The justification for this analysis is that Botswana currently does not have a national GBV strategy, as it ended in 2020. The Botswana National GBV Strategy 2015 to 2020. And in the context of high rates of GBV recorded across the Southern African region, which Botswana is a part of, the SADC Regional Strategy on GBV provides some useful guidance for national action plans for countries in the Southern African region. And thirdly, few, if any, existing GBV estimates include measures of emergent and understudied forms of GBV. There's also insufficient data on emergent and understudied forms of GBV. And in cases where there is some data, the data is actually old, underscoring the SADC Secretariat's concern about the need for reliable statistics on IPV and some other forms of GBV within member states, including Botswana. And in terms of the context, just the GBV context in the region, the prevalence of lifetime experience for GBV is between 50% and 86% across Botswana, Lesotho, Mauritius, South Africa, Zambia, and Zimbabwe, which underscores the fact that it is really prevalent and pervasive in the continent, in the region. And in Botswana specifically, 67% of women will experience some form of GBV in their lifetime, based on measures of physical, sexual, and/or emotional IPV and non-sexual partner violence. There are critical gaps when it comes to the scope of legislation to respond to online violence, which is not well understood. And lastly, intimate femicide evidence is not widely monitored, but newspaper reports do provide some information. In doing this analysis, the following methodology was utilized. 1, exploration of the GBV prevalence and challenges across the region and Botswana specific. Secondly, review of the SADC strategy for discussion of emergent and understudied forms of GBV. And lastly, review of the expired Botswana National GBV strategy for discussion of emergent and understudied forms of GBV. So these were the results from the document review. In the Botswana National GBV strategy, these are the existing gaps. There are gaps in acknowledgement of diverse forms of emergent and understudied GBV. Secondly, there's no direct articulation of prevention, legal and judicial protection, and knowledge management on tech-based facilitated GBV, including issues of online sexual harassment, cyber stalking, revenge pornography, image-based abuse, etc. And thirdly, there is no specific guidelines or reference to specifically femicide, including intimate partner femicide, or how murders amongst women are gender-based. In the SADC regional GBV strategy, there is discussions that member states need to have systematic and reliable data and information on GBV as a whole, including emergent forms of GBV. There's that articulation. Secondly, promotion of multidisciplinary research and analysis on the structural causes of GBV and its different types, including the emergent ones, the understudied ones. And lastly, this regional strategy underscores the need for improvement of the collection, harmonization, and use of administrative data from the police, the health and judiciary sector on diverse types of GBV, which would be inclusive of intimate femicide and tech-based abuse. After the analysis, these were the recommendations. The upcoming national GBV strategy of Botswana should, 1, define emergent and understudied forms of GBV, such as tech-facilitated GBV and intimate femicide, and acknowledge their role in overall GBV practice and measurement strategies. Secondly, data gaps. There should be strategic inclusion of support of research, data collection, and analysis on the different emergent and understudied types of GBV in Botswana. Thirdly, inform policy. The strategic collection and use of data to inform policy on emergent forms and understudied forms of GBV in Botswana, a policy-informed or a data-informed policy. Lastly, guide practice and services. There should be guidance for prevention, response, and technical capacity building for relevant stakeholders and service sectors to address emergent and understudied forms of GBV, such as intimate femicide, as well as tech-facilitated abuse. I thank you all.
Thank you so much, Lorato. That was a really interesting policy analysis, and really appreciate you highlighting some of those gaps, particularly for some of those understudied forms of GBV that we've heard further about in our earlier presentations. At this time, I would like to invite our speakers to turn their cameras on and join us for the Q&A. Again, if you have a question, please put it in that Q&A chat function. If you can't find that for some reason, you can also just put it in the chat, and we will go through those. So, gather those questions now. We're going to do a little bit of a round robin. I see that we do have some questions in the chat already. It looks like they're primarily focused on our first few presentations. So if you do have, other thoughts, or some of this discussion sparks additional questions, keep adding those. Okay, so our first question is for Nada, thinking about some of these characteristics or risk factors for women who are facing higher rates of tech-facilitated GBV. Thinking about, is there, a profile of women potentially that are experiencing TF-GBV? She says, for example, I recall women that experience most TF-GBV are between 20 and 40, also those of higher education. Could it be possible to conclude that young women that study at the university are more present, use social media to advocate on issues that could offend groups, and therefore would that potentially make them more prone to tech-facilitated GBV?
Thank you, Shannon. Thank you for the question. Well, I mean, it would make our lives much easier if we could establish one profile for victims of TF-GBV, but unfortunately, the prevalence rate in Tunisia is so high, and across the world, actually, it's so high that trying to establish one single profile for victims and survivors would inevitably exclude other women, and it wouldn't really help us in prevention work. Because if you look at the demographic factors that we analyzed, I mean, the difference between each category of those factors is not that big. So we would have one dominant category in each factor. So, for example, the highest level of educations are at higher risk of women with higher level of education are at higher risk of TF-GBV, but doesn't mean that other levels of education are free from that risk. So we opted to run regression analysis that allowed us actually to determine if those factors are actually like that would determine any potential higher risk for women and girls, and that was the case in our study. I hope this answers the question.
Yeah, we have a very similar question next for you. So I'm going to go ahead and read that one as well, if that's okay. Amina is asking, did you assess the contextual socioeconomic parameters as it relates to survivors' access to technology per reporting and its implications on this evidence?
Well, that is a very good question, Amina. Thank you. Unfortunately, we couldn't analyze the contextual socioeconomic parameters because we're restricted with the data set that we have. So as I mentioned in the presentation, this is a secondary analysis of a data set that UNFPA initially gathered. We did not have enough information to be able to determine those factors and to make those links. It would require another survey. It also require more of a qualitative approach. That would, holding focus groups, for example, would allow us to go in depth into those factors. But with quantitative data, it would be very complex. I mean, it wouldn't do it justice to analyze those factors that way. The issue with the data set that UNFPA collected is that it was the survey was conducted through phone. And phone surveys usually have a limited time duration, so you're not supposed to exceed, let's say, like 20 minutes or something, so that the respondents don't get bored and give up on answering. So you want to keep it as short as possible. So asking about those socioeconomic factors would make the questionnaire much longer than we were able to. We had to make it actually.
Great, thank you so much. Okay, our next questions are really focused on the Kenyan context. So Abigail, we're going to hop over to you. The first question here is about criminalization of IPV in Kenya. Balaam says that impunity is one of the key challenges in help seeking. And kind of building on that, Jigme is wondering a bit more about how you categorize professional and non-professional women.
Thank you so much for the question. So the first one, which is IPV criminalized in Kenya? So the answer is yes. So in the Kenyan context, we find that laws are not the problem. So we have so many laws. First of all, Kenya has ratified so many of the international conventions and treaties. At the same time, we have locally enacted so many laws that criminalize domestic violence. So we do have, for example, we have the Protection Against Domestic Violence Act, we have the Sexual Offences Act, and therefore the issue does not lie on the laws. However, just like you've mentioned, the major problem that we face in terms of this is the weak implementations of these laws. The first weak link that we meet is when we move to the police. So you find that survivors in Kenya, so in the Kenyan context, you find that the police are supposed to do the investigation, or we're supposed to report to the police station. And in our police stations, we have what we call the gender desk. So they're supposed to receive the cases and be able to assist the survivors. However, because of the cultural attitudes and norms, most of the time you'll be told that this is a family issue, and you can be able to solve it within the family. And therefore, you find that most of the time the cases do not get to see the court or even to get any assistance. At the same time, you understand the issues of cultural stigmatization and the shame that comes with this, and that most people do not follow up on the cases. And therefore, that brings a challenge to the implementation of the laws. Whereas the laws are there, but the implementation and cultural norms really pose a big barrier to survivors seeking help. And to the second one, that how did I get to categorize professional and unprofessional women? So we use the definition of the demographic health surveys, whereby they have given a clear definition on what they constitute professional status. For example, when you look at the demographic health survey, you meet that we have the armed forces, government workers, department managers, lawyers, teachers, accountants, and many other more who are categorized as professionals. And that is the definition that we use to categorize that. Back to you, Dr. Wood.
Great. Thank you so much, Abigail. The next question is actually, I think specifically to Abigail, but I want to open it up to both Abigail and Lucy. As both of your presentations were really focused on help seeking. Again, this one's from Jigme, and she's saying that even in Bhutan, formal help seeking behavior is very low. This was a recommendation that came from Abigail's presentation, but can you explain how adopting the power of storytelling from survivors of IPV would reinforce positive attitudes towards help seeking? How do you ensure that it's done ethically without causing more harm? So Abigail, Lucy, I'll turn that over to both of you, but really just thinking about some of these implications here and how we can counteract some of those negative reinforcements.
Okay, if I can go first, then Lucy can pick. So thank you so much. And I want to use the practice that I use with my community-based organization, where we utilize the power of storytelling a lot. And you find that it does help a lot in breaking the silence. So like we've already seen, one of the challenges in help seeking is not coming forward, not talking, the shame, the stigma that is associated with being beaten. So in Kenya, we call it wife beating. And most of the time it's done to discipline the woman, and therefore it is accepted. But when we have people sharing their stories, we find that we are able to break that silence. We are able to challenge that kind of cultural norm. And person listening is able to learn that they are not alone, that they can be able even to learn some of the referral pathways. So you get to learn that if you seek help in a police station, you'll meet a gender officer. This gender officer is well trained to be able to take you through all the process. At the same time, you're able to understand the counseling procedure. You're also able to understand some of the bodies. Like, for example, we have FIDA, which is a made up of lawyers, and they give legal aid to survivors. So you find that power of storytelling can really open up help-seeking behaviors among survivors of intimate partner violence, and to ensure that it is approached in a good way. So one approach is ensuring that we don't, if we are using someone is giving the story, you do not use their face, so you can blur it a bit, or you can be able not to give their real name if you're writing down. So you don't give the name so that you can be able to ensure the survivor safety and also their confidentiality. At the same time, you allow a survivor to be able to explain the story in their own way. They're not pressurized to be able to state it in this way or in another way. You allow them to be able to give their stories as they feel like. And in the process of storytelling, you also approach it in providing counseling or psychosocial support to the survivors, so that you can be able to offer them emotional and social support. I can maybe allow Lucy to pick up from them. Thank you so much for the question.
Thank you. And I think most of the thoughts that I had are very much in sync with what Abigail just mentioned. But just want to say that I think it is very much crucial that to make sure that it is done ethically and without causing any harm. We use a trauma-informed approach, and that may include different aspects. For example, using informed consent and anonymity. We should make sure that these survivors are sharing their stories voluntarily, and they have a full understanding of how their narratives are being used. And it is also important that they have control over what kind of details are being shared, and that they have the option to withdraw at any time that they want. And as Abigail said, it is very much important to provide counseling services before and after they share their stories. And I think there are a lot of aspects that can come into play, but these are a few that come to my mind for now.
Thank you so much, Lucy and Abigail. Really appreciate you highlighting particularly some of those ethical pieces that need to be in place to do this work. Okay, our last question in the chat for now, unless there are more, is for Lorato. Thinking about what strategies you suggest for synergizing data to drive policies across a multi-sectoral system in Botswana.
All right, thank you very much, Dr. Shannon, and thank you to Amina. Good morning, afternoon to everyone. So there are a number of strategies that I could recommend. Firstly, I think it starts with a central coordination framework around GBV data, and that could include something as simple as having a GBV data task force with very clear roles and a very clear governance structure, and have multi-sectoral representatives, and it could even be interministerial in nature. So at the top of my head, I'm just thinking social services, civil society, academia, justice, education, health sector, just coming together to form that task force. That's one. And secondly, it's important to, as a strategy, to develop standardized data protocols with core indicators and give common definitions for GBV. Across different sectors, across its different formats, and align those with international frameworks. And it's important for Botswana because in some of the reportings around intimate femicide, you see that the language used is not consistent with the standardized data protocols in terms of the indicators, in terms of the language. So it's also important to align everything so that there's a common language that is in line with international frameworks. And then also deliberate and intentional disaggregation of data by core factors, right? So it's not enough to just stop maybe at age or locality. We could go beyond the key factors surrounding some of these GBV factors to be able to get to the core of some of the sociocultural, economic, and political issues surrounding GBV, so that when the policies come into place informed by data, we have all the information. And then thirdly, data management as a strategy, that it's important to invest in not just access to data, but the data collection systems, ethical procedures informing the data collection, the reporting, the analysis of the data. It's not enough to just stop maybe at quantitative, but it's also important to push through to qualitative, where we get the why of maybe the numbers that we often see. And then capacity building, it goes without saying that we have to train service providers, train policymakers on data literacy, on data management. And this, I'm hoping, could also lead to a development of a GBV data dashboard, which we currently don't have. So if you're looking for information in real time in any type of GBV, you can't exactly get it in real time. So these are just some of the strategies that would be helpful for driving policy and action. Thanks. Well, regarding data. Thank you. And I hope I answered you sufficiently, Amina.
Thank you so much, Lorato. Those were really, really great suggestions. I am not seeing any more questions in the chat. We do have a few minutes left, so I have one question for all of you, and we can just do a quick round robin on it. But what is next for you? You know, how do you see yourself building on the skills throughout that you've learned throughout this program, and also the work of your mini project? So, Nada, can I go to you first?
Yeah, sure. The answer for me is pretty easy. It's advocacy and advocacy and advocacy. The reason behind that is that what I noticed from my experience is that our advocacy at this level has been somehow weak, because it lacked the backup of tangible data that would be convincing enough to implement the whatever we were suggesting in our advocacy work. So what I take from this fellowship mostly is the learning of how to back our recommendations by data, how to back it by evidence that cannot be denied in any way, and that would make all our efforts way more effective and way more efficient in the long run.
Amazing. Thank you. Yes, so much power in data. Abigail, over to you.
Thank you for that question. So what's next for me? Like what I said in my study is that we need to be able to explore further on mechanisms and types of help seeking by professional status. And I think that is where I've started and working on a paper to be able to understand more about the help seeking, but specifically for women legislators. So be able to look at where we can be able to enhance their help seeking behavior. At the same time, the fellowship has also equipped me with advocacy on the field of GBV, and we'll keep on working on the same in terms of policies, in terms of research, providing evidence-based research to be able to support the advocacy work in GBV. I believe that's what I can say. Thank you.
Thank you so much. And Lucy?
Thank you. Actually, the fellowship has done an amazing job to strengthen my research, data analysis, policy translation skills. And I would definitely love to expand the research that we conducted on the GBV service accessibility if there is a chance as such. And I would definitely also like to further expand my knowledge and skills academically in the GBV topic altogether, and I will definitely try to pursue that.
Excellent, thank you. And Lorato?
All right, thanks. I think like Nada, the next steps really is to continue in advocacy work. This policy analysis is sort of also directly linked with my PhD studies. So I'm hoping that the work deepens my own PhD studies. And I think beyond this, it would be important to also join efforts, collaborative efforts with other key actors in Botswana who are doing such amazing work. Currently, intimate femicide has really been high in the country, where almost each week we get newspaper reports of somebody being murdered by their intimate lover, whether ex-lover or would-be lover or current lover. And there've been some collectives who've been doing a lot of amazing work online, including the GBV SOS, which is a collective of gender activists in the country. So it would be important to join hands with such collectives to share information as well, so that if there's any utility for this policy analysis, it can go beyond the work. And I think it would also be important to lobby the country. Like I said, intimate femicide is rampant, and we have all sort of wanting it to be declared as a national emergency by the president. So this is an entry point to also lobby through to the minister responsible for gender, and eventually have the country declare intimate femicide as a national crisis and emergency. And yes, I wish to continue learning, peer learning from everyone, as I have done through the program, including through the mentors at Johns Hopkins. So, yeah.
Thank you, everyone. This was just a really wonderful discussion, and appreciate all of you highlighting the power of data, that advocacy is so important. And, you know, I'm seeing some comments now in the Q&A about just news coverage and needing that data to really back up what we're hearing qualitatively. So thank you all for these fantastic presentations. Really, you know, different contexts, but many of the issues are so cross-cutting and similar. So thank you again for these presentations and just being part of this fellowship program throughout the year. It's been a real pleasure. At this time, I will turn it over to Dr. Michelle Decker to close us out.
Wonderful. Thank you so much. I just want to give a huge thanks to our accelerators for the incredible work that we had a chance to hear about today. Tech-facilitated violence, policy analysis, how do we carry this work forward, access to help seeking and help services and awareness of those issues, and the unmet needs for women across the professional spectrum. I think you as accelerators have really embraced and expanded our evidence both in country and also our ability to move this forward, and especially appreciate the very specific points on policy analysis and how do we keep this evidence-based moving forward. And for those of you that are online, thank you again for joining us today. I really invite you to follow our work through the center, through our LinkedIn page, and stay tuned as we continue to spotlight our accelerators and even consider our final webinar in the series, which will be held tomorrow. So thank you again, very much appreciated. And here we go, carrying the torch for gender equity and gender-based violence and the evidence base that is needed for that work. Thanks.